There's a very good drug, for example, that's under development. And this drug has been shown it reduces cancer, reduces cardiovascular disease, may be protective for Alzheimer's, helps with diabetes. And that drug is called exercise. And we've done a lot of research on it, and we know it's very good. But there's no incentive for anyone in our healthcare system to take older people for a walk. And yet we know that would be extremely valuable.
From the USC Leonard Davis School of Gerontology, this is Lessons in Lifespan Health, a podcast about the science and scientists improving how we live and age. I'm Sean Curran, Associate Dean of Research.
And I'm Orly Bellman, Chief Communications Officer. On today's episode, how economist Dana Goldman is working to improve health and reduce spending by calling for policy changes that reward prevention, innovation, and long-term investments in people of all ages.
As lifespans have increased, so too have the costs for caring for our aging society. Healthcare spending currently accounts for nearly 20% of U.S. gross domestic product, and that number is only expected to increase.
You know, the United States, if you look at us as a country, between the Social Security program, Medicare, Medicaid, and defense, and interest on our debt, 85% of all government spending falls into those buckets. Another way of saying it is, I think Ben Bernanke pointed this out, is the United States is a health insurer with a Navy.
But Goldman, director of the USC Leonard D. Schaeffer Center for Health Policy and Economics, says it's short-sighted to view this as a fiscal issue.
Everyone wants to lead a full, rich life with as little disability and morbidity as possible and a very humane ending to that life. And I'm a little concerned that in the current debate, we tend to focus mainly on costs and insurance. And the questions around aging are much broader and more dynamic than the current policy debate gives it attention.
Goldman is a Distinguished Professor of Public Policy, Pharmacy, and Economics. He also holds a joint appointment at the Leonard Davis School of Gerontology. His cross-disciplinary research reveals the value of pursuing better health.
Historically, the way we've paid for healthcare is we paid dollars for volume of services. So you have an office visit, you get paid. And the system has responded by giving us lots of volume of healthcare services. But that's not actually what people want. I mean, they aren't looking to go to the doctor every week. What we really want as a society is good health. We need to pay for health, not health care. And if we do that, then we'll be able to accumulate some savings out of the system that I think would help pay for all the other types of infrastructure investments that would make sure that people lead wholesome, long, productive lives.
Can you tell me more specifically what it is we should be focusing on?
Yeah, I'll give a good example, which is giving someone insurance doesn't magically extend their life. You know, it turns out there isn't much that magically extends someone's life. One of the few things it turns out to be is education. And investing in education has a whole host of benefits for kids, especially at earlier ages. And when you're leading these lengthy lifetimes, you know, these types of investments have long-tailed returns. And we've shown, for example, that if you take disadvantaged kids and put them in productive pre-K environments, it can pay dividends that are better than the post-World War II stock market once you've monetized out all the costs. And so we talk about infrastructure investment in the United States, but part of that infrastructure is our human capital, not just our physical capital. And it's true that our roads are wearing down and our airports are a mess, and we're starting to make investments to improve those, but we're not really investing in kids, I think, the way we should. And if we think about this not as a health insurance issue, but as a health issue, then the set of investments that you might make in people expands quite a bit.
This expansion, says Goldman, also needs to include the time span for which proposals currently get evaluated in Washington.
People who are policy wonks know the Congressional Budget Office has to score every bill. And their window, which is tradition in the legislature, is to score them over a 10-year period. So if I have an investment that is going to, like early childhood education, that doesn't pay returns for 40 or 50 years. That would show up as a cost if it got scored by the CBO. And we really need to start thinking about, when we have an aging society, we have to think longer term, and we need to get out of this short-term thinking about budget cycles and the like.
Goldman says it's time to focus on strategies that can delay diseases or prevent them from occurring in the first place.
If you think about the arc of human progress and you look back over the last century and you say, what has contributed to increases in life expectancy? Well, a lot of it were interventions that weren't really healthcare focused. They were clean water, clean air, improved workplace conditions. We don't have people breathing in coal dust in the way they used to. And getting people to stop smoking. And you combine that with the introduction of vaccines and some other innovations, and we've been able to extend life quite a bit. But what happened is, as we extended life, we started to see a constellation of diseases we hadn't really dealt with before. Cardiovascular disease and more recently, cancer. And the model we developed for treating these was very disease specific. We want to deal with your heart attack. You go see the cardiologist and the interventional surgeon if need be. And we tend to address problems in a very atomistic manner. But what's really happening is we've become victims of our own success, and we know that people now have a constellation of chronic diseases. And dealing with just one of them becomes a game of whack-a-mole, if you will. And what we've shown this in our research is to think about how can we prevent disease and prevent many diseases in a way that will extend life and also reduce the morbidity. So we don't just want people to stay alive, we want them to stay alive in a state that allows them to enjoy all those opportunities that we discussed earlier. And so our research is really focused on this. And, if you think about it, there's a very good drug that's under development. And this drug has been shown it reduces cancer, reduces cardiovascular disease, may be protective for Alzheimer's, helps with diabetes. And that drug is called exercise. And we've done a lot of research on it, and we know it's very good. But there's no incentive for anyone in our healthcare system to take older people for a walk. And yet we know that would be extremely valuable.
So why is it so hard to reward prevention?
Right. Well, part of it is it's not something that anyone has any intellectual property rights over. If I develop a pill, I have a patent system that gives me some protection. And if I take the risk to figure out some way to get this to patients, I know that someone can't copy it until my patent has expired. And that has encouraged the development of a lot of pills. But if I come up with a way to get you to walk or eat better or something like that, it's very easy for someone to copy that. And so you can see that the playing field is tilted more towards treatment and away from prevention just because of the way we think about intellectual property. But combine that also with the following notion. We have an entire system of health insurance that says, I'm going to pay for treatments. So if you come up with a way to keep people healthy and keep them healthy, And a health insurer will say, I'm not paying for that because the person's not sick. So what the health insurer is essentially saying is, I don't want people to get diabetes, but if they're healthy, you're on your own. If they get diabetes, then I'll pay for all those treatments that they need. That's not the way we should be designing our public policy.
Are there any signs of progress in that area?
I think so. First of all, we're getting much better at predicting who is going to have the consequences of disease. I mean, one of the really interesting biomedical questions, for example, is if we can come up with easy ways to identify cancer, for example, with blood-based markers early on, and we would really change cancer from a potentially life-threatening illness to a chronic disease. That has great potential. But there are other things we can do. We know people who may be at risk. And actually, some of the work that people are doing on socioeconomic disparities in health have identified neighborhoods and communities where people are at risk because they don't have access to some of the resources that might improve their health. And so if we're able to transition our resources to reward that type of prediction and then acting on it, then we will start to move in the right direction. Kaiser, for example, has been able to eliminate health disparities in things like hypertension and diabetes in their population. And Kaiser keeps people for years and years, and they have an incentive to address that. And the question is, how do we do that on a broader scale?
Alzheimer's disease provides a case study in why we need to pay for prevention, says Goldman.
We've been able to extend lives so long that people are starting to see these neurological impairments cognitive impairment at older ages that we need to do something about. But the problem is that by the time someone has Alzheimer's, it's probably too late. And so you really want to have a prevention strategy to address this. And prevention may mean going back decades earlier and identifying people at risk and doing something to help maintain cognitive function very early. Our system is not designed to do that in any way, shape, or form. And health insurers right now who are pressed to keep premiums down don't want to be paying for something where all the benefits are going to accrue to the Medicare population decades later. And so we really need a better strategy for dealing with the economics of Alzheimer's. And this all comes down to prevention. I think the right solution with Alzheimer's is we need to prevent it early. And we got to figure out how to pay for that. And it's really showing the problems with our social insurance system, the way it's structured today.
Goldman says medical innovation is key.
I was diagnosed with type 1 diabetes at age 29. And at that time, I did a calculation in my head, and I said, if I just take care of myself for the next 30 years, there'll be a cure. Actually, I said 20 years. I'm now older than 49. There is no cure. I have been taking care of myself for 20 years, but I'd really like to live to see one. And I especially worry about that if there's a strong genetic component to diabetes, and God forbid one of my children should develop the disease, I would really want to see it. And this intergenerational dynamic model of innovation in healthcare, we underinvest in prevention, first of all. There's no incentive to develop a cure, and no one is talking about how some of these tensions will actually affect our ability to innovate.
Another Goldman recommendation: rethink retirement.
The United States is a little less generous than other countries. Some other countries have retirement policies that allow you to retire at age 55, and lo and behold, people do that. And, that is, to us, that would seem like a very young age. And we've seen that these gradual changes in Social Security have encouraged people to stay in the workforce. And actually, what we find is people are extremely productive. For those of us who work in aging, for example, I'm always astounded that I'm the youngest person in the room and I'm the least productive one. And there's all this untapped potential if we do it right, and we got to figure out how to do it. And there's even some evidence, for example, that intergenerational work teams, so where older people working with younger people, can be more productive than just younger people or just older people. And, being at a university, that's the nature of our production function. So I'm a firm believer in that.
How do we prepare to be an aging society?
Yeah. I think there's a constellation of social policies that would really help deal with these demographic trends that are very basic and global. And these involve getting more productivity out of people when they're healthy, investing earlier, because now decisions we make as teenagers could affect our lives for literally 80 years rather than 20 years. And other attempts to deal with the consequences of people living much longer. So a good example of this is loneliness. If it used to be that as people live longer, there's a good chance that people will outlive their spouses, and we have fewer households anyway, where they're married couples, for example. And how do we deal with that? And how do we make sure how do we use technology, for example, to make sure that people have communities and they're not isolated socially?
The goal now is to help all people improve the quality of their lives.
Who doesn't want to be around to see their grandchildren and great-grandchildren prosper if they can do that in good health? And our point of view in our research is to say, how do we develop sound policy to get to that objective?
That wraps up this lesson in Lifespan Health. We'd like to thank Dana Goldman for his time and expertise, and thanks to all of you for listening.
Tune in next time for another lesson in Lifespan Health, and please subscribe to our podcast and learn more about us at lifespanhealth.usc.edu.